Okay, so want to introduce next speaker is Dr. Damian Raush. He's a colleague and a friend of mine. He currently works at Scripps Encinitas, and he is a general cardiologist. And I have asked him to speak about the latest trials in cardiac imaging, invasive cardiac imaging, and non-invasive as well. So it's a big task. His background is that he did medical school at LECOM in Bradenton, Florida, and then did his residency in Cleveland Clinic and fellowship in Chicago, near Chicago, Kankakee. And he is here to present, and we're honored to have him today. And hopefully he'll also come in the future for more talks. Thank you.
Thank you.
Barrel situation here.
Sorry about that. Yeah.
All right. Well, afternoon. Is it afternoon? We made it, or is it still morning? I don't know. You're still morning, believe it or not.
All right, so my name is Damian Raush. I'm a general cardiologist. I'm at Scripps Practice Cardiovascular Institute. That's where I do my procedures. And then I'm also on staff at both of the memorial hospitals. And then I'm actually part of, I think we're the largest private group left actually in San Diego Cardiovascular Associates. And we have offices on the campuses of both of the Scripps hospitals. And so Dr. Nanavati and I are both Chicago Bears fans and have ties going back to Chicago. And so the joke was I lost a bet. I got to do the imaging portion of today's talk. It's a tricky topic, especially when you're talking to a group of cardiologists, because if I'm being frankly very honest, imaging and the imaging literature is a lot different than most of the stuff that we're typically used to reading with these really good, robust, randomized, prospective controlled trials. And there's kind of a lot of reasons for that. I think part of it is that most of the imaging literature is trying to look at the accuracy, diagnostic accuracy, sensitivity, specificity of whatever particular image modality we're talking about. And they're really focused on that very heavily, and not as much literature really looking at outcomes and how the imaging drives outcomes. It does exist, but it's very hard to randomize stuff like that because there's always this fear with IRBs that you're going to randomize somebody to an inferior diagnostic modality and you're going to miss something dangerous. So that's the tricky part. And so a lot of the trials, in these journals, quite frankly, are ponderous. We're not moving. Here we are. Okay. So I tried to pick some of the more interesting things, and this is going to be a little bit probably different than some of the stuff we've seen here today, just because I really want to focus kind of at that 10,000 foot top level of sort of clinical implications of some of the stuff that's come out this year. So we're going to do this kind of in a journal club sort of format, like back in the days of our old morning reports and stuff, where, we'll talk about the clinical question, very cursory overview, trial design, populations, results, and kind of the clinical takeaway and bottom line. So we're going to look at really 4 trials because one, we're calling it 5, but one is really just a subgroup analysis of the CONFIRM registry. So we're going to look at Orphan. We're going to look at CONFIRM 2, iModern, and CERTAIN. There we go. So, here's how I'm going to try to frame the talk. We have probably since the 90s always had this very stenosis-focused view towards atherosclerotic cardiovascular disease. And that's been our traditional sort of viewpoint is that, we look at a lesion, we, estimate or try to quantify how stenotic it is. And there's just been this very strong clinical focus on obstructive coronary disease. A lot of that I think is driven by the advents of angioplasty and stenting and our percutaneous interventions that have really evolved into something spectacular in this day and age. But there's always this sort of lurking kind of elephant in the room that, we now know with registry data and all the great stuff that we have that 70% of these horrible cardiac events we've seen in our patients occur in patients that by definition have non-obstructive coronary disease. So in the 2010s, we were very stenosis focused. 2020s, we started poking around a little bit and asking ourselves, what are these plaques looking like? If anyone's taken interventional boards, you've lived through the misery of some of the Q&As on plaque analysis. And now, as we're kind of looking towards the future, 1 year ago at this conference, we were just sort of, barely talking about AI and what it was. And in the 12 months that have ensued, now we've unleashed open evidence on the world and all of these cool new tools that are coming. And so we're starting to see some of this creep into the world of imaging. And we'll talk a little bit about that in some of these trials. So why does stenosis alone fail? Most MIs occur when plaques are less than 50% stenotic. And visual assessment fails to capture total plaque burden. And my favorite topic to complain about, which is coronary artery calcium scoring, really only captures calcific plaque burden. And we can talk about why calcific plaque burden is clinically relevant. And another big problem is that women are systematically underdiagnosed, and that's a massive point. So touching base on sort of what's old and what's new, why are we now so focused on plaque burden? Well, going back to our favorite tool in our toolbox, which are statins. We've known for many years that statins have what we call pleiotropic effects. They have an anti-inflammatory action. They lower inflammatory markers like C-reactive protein. They inhibit matrix metalloproteinases that are sort of what eat away at that fibrous cap that's trying to stabilize the plaque you have so it doesn't rupture and give you an MI. They upregulate endothelial nitric oxide synthase. They have antithrombotic effects, antioxidant effects, etc. So trial 1 is the orphan trial. This is the Oxford Risk Factors and Non-Invasive Imaging trial that looked at inflammation risk and cardiovascular events in patients without obstructive coronary disease. This was published in Lancet, technically 2024, but we're going to put it in the 2025 box for the purpose of our discussion today. We're going to talk a little bit about what fat attenuation index is, and you kind of need to know a little bit about how this works under the hood, just so you can understand what this trial tried to do. To the left, you see a cartoon, and you see an enhanced CT image of a vessel, a lumen, a coronae, let's call it, with very low levels of inflammation. To the right, you see a very highly inflamed blood vessel, and the red obviously reflecting that. So fat attenuation looks at inflammation around the coronaries, and it can detect changes in fat tissue before plaques can even become visible on CT scans. And so the way it works, sort of technically, we use existing CT scans, so you don't need any extra radiation, you don't get any extra contrast bolusing or anything like that, but we take that, we give you a 3D color map, and we sort of pose that over standard imaging, and we can see a bunch of inflammation that the standard scans tend to miss. And why does this matter? This goes back to the picture you see here is derived from something called the CRISP-CT study. It was a large study with about 4,000 patients across multiple countries. What they found was that patients with abnormal fat attenuation index had 6 to 10 higher risk of cardiac death, 5-fold the risk of heart attacks, and that this predicts risk even when accounting for other risk factors like being diabetic or smoking, etc. And it works independently of all the other high-risk features that we see on scan. But again, these people have coronary disease, so it's obstructive. So the question in orphan was, among patients undergoing clinically indicated coronary CT angiography, does coronary inflammation assessed by perivascular fat attenuation indexing predict cardiovascular events independent of stenosis severity and other traditional risk factors? And so this matters, obviously, because if we can do this, this is going to allow us to sort of see things that we have never been able to see before and really start to take a very different look and start to move outside of that stenosis paradigm and really start looking at the biology of plaques and trying to find people farther upstream as candidates for primary prevention. And so if 70% of events, like we said, occurring in non-obstructive disease, so here's how it was roughly designed. It was a multi-center longitudinal observational cohort study, again, not randomized for reasons we talked about. We have consecutive adults that were referred during over a decade, and they looked at fat attenuation on routine CT coronaries, or 40,000 patients. 81% had no, by definition, obstructive disease, which we're calling nothing greater than 50% for the purpose of this. We took out CABG patients and folks like that. The primary outcome was MACE, which is obviously MI, heart failure, cardiac death. And so we looked around those major arteries and we stratified them, basically looking at low versus high inflammation. And the sort of key innovation here is that we can see a significant predictive value to this. So there is a 2 to 3-fold increased MACE risk in patients that had high fat attenuation. 81% we had non-obstructive coronary disease, and you could see a stepwise increase as that went up. So patients without obstructive coronary disease had the majority of MACE and cardiac death. So these are people that did not have major blockages that would normally kind of get our attention in the cath lab or even on conventional CT coronary angiography. So if you had a high FAI, you had that 2 to 3x increased risk and mortality, and it increased stepwise. And even after we adjusted for things like stenosis, plaque burden, calcium scoring and stuff, that effect was fairly robust. So the criticisms of this, I think, are fairly manifest. It was an observational design. There could be residual confounding. Inflammation was sort of inferred indirectly from that adipose tissue that's perivascular. And we don't really have a lot data yet at this point. This is sort of, chapter 2 of looking at FAI-guided management when we pair this with therapeutics to see if we can actually move the needle on some of this stuff. So, next slide. So here's the bottom line. Coronary inflammation identifies a high-risk phenotype that's invisible to a stenosis-only tunnel vision assessment, and it can identify high-risk patients even without obstructive disease. So don't dismiss normal CT coronaries. Start thinking about looking for inflammation markers. We'll talk about ways you might be able to start doing that in 2026. Patients with this high FAI should probably be managed more aggressively in terms of their risk factor reduction. I would not accept a triple-digit LDL in a patient with a high FAI. And it's my last slide. Yeah, an indication potentially for some anti-inflammatory therapies. I think that's food for future thought. So what do guidelines say about this? The short answer is not much as of yet. So ESC guidelines, which I still think are the more forward-looking and progressive guidelines, which I tend to lean more on even in my American practice here. Risk stratification is still largely stenosis and ischemia-driven. There may be some future incorporation of inflammatory markers, but that has not really hit the press yet. And very similar on the ACC side. There's some discussion of intensified medical therapy and higher risk, but we haven't really hit guideline level yet. But impact on your practice, normal or mildly abnormal CT coronaries should not automatically reassure a patient because there still could be these things lurking below the surface, okay? Trial 2, this is the Confirm-2 registry. We're going to start talking about women's sex-specific analysis. This used AI quantitative CT to look at sex differences in coronary disease to try to answer the question of why women seem to be underdiagnosed. This was published in JACC, again, a little bit before 2025, but it's, again, really hard to find interesting topics in this area that move the needle. So apologize that it's a little bit older than we'd like. This was done out of Innsbruck, actually, and I think I put this up here because one of the guys at University of Chicago that trained me, Dr. Amit Patel, was one of the major contributors to it. But the question is, among symptomatic patients without known coronary disease, does the prognostic impact of plaque burden differ between women and men? So it's a multi-center observational registry. Patients were referred routinely for CT coronaries for suspected CAD, and then we applied to those scans were a centralized AI-based quantitative plaque analysis that was proprietary. 3,500 patients, half of which were women, relatively healthy patients in terms of no events from a vascular standpoint, no prior MIs, no PCIs. None of them had been revascularized or had anything bad happen up until that point. And what they found was that there is a 2 to 3x higher relative risk per plaque increment in women versus men. lower absolute plaque burden in women than men. That's not surprising. I would speculate that's probably from estrogen in younger patients driving that result. But and then equal prognostic impact after adjustment. So men exhibited higher absolute plaque burden, had more CAD, and then for women, any incremental increase in plaque burden, they had substantially higher risk of MACE, 2 to 3x higher, and coronary artery calcium alone. Clearly, if you take away nothing else from this talk, and you have female patients in your practice, which you should, coronary artery calcium definitely underestimates women's risk. And I do think AI quantitative CT is going to help correct that. I don't know that we're 100% there yet, but it's coming. And the bottom line here is that a coronary artery calcium score of 0 absolutely does not rule out significant disease in women. We should not use that as a reason to not start someone on therapy if their LDL is high or their blood pressure is high, which unfortunately I think is how a lot of people are using it. So again, these are what the guidelines currently say about it. Nothing super interesting. They've obviously acknowledged the phenomenon. There's an under recognition and an under treatment. And we should probably have lower plaque thresholds to try to get these women on therapy earlier than we currently are. Third trial, confirmed 2, non-calcified plaque volume analysis versus stenosis severity, which predicts events better. Again, also same folks in JACC cardiovascular imaging. Does non-calcified plaque predict adverse cardiovascular events independent of stenosis severity and plaque burden? Sub-analysis from that same registry, again using quantitative CT composites. Longitudinal follow-up for CV outcomes, 6,500 patients. Quite a spectrum of lesions in these patients, but it did include some with non-obstructive coronary disease. And what they found was super interesting. So we look a lot at these things. What are we looking for with quantitative CT? Well, they look at total plaque volume, the amount of non-calcified plaque, that's probably a better term than soft plaque, low attenuation plaque, calcified plaque per segment. So some people don't know a lot about what low attenuation plaque is. This is the worst kind of plaque. This is the one you don't want to have. It's a very high risk non-calcified plaque. It's technically defined as plaque that has less than 30 Hounsfield's units. But it's a lipid-rich, soft, and very unstable necrotic core in that plaque that's very, very prone to rupturing. And it is a major precursor, and we can now pretty much say it's a predictor of heart attacks.
Wow.
So higher non-calcified plaque volume strongly associated with increased MACE risk. The association persisted after you adjust for stenosis and severity of the coronary artery calcium. Non-calcified plaque burden outperformed stenosis severity as a prognostic marker. Think about that for a second, and you think of the way we practiced for the last 40 years. Non-calcified plaque burden outperforms stenosis. And even with less than 50% stenosis, high NCP equals high risk. Low attenuation plaque, the worse. You don't want that. This is what guidelines have to say about it. Coronary artery calcium is emphasized, but we have not really gotten to the point yet where we're emphasizing or talking about non-calcified plaque in the realm of primary prevention, at least with ACC. ESC, at least conceptually, is talking more about it, but we don't have any specific recommendations yet. How should this impact your practice? In my opinion, non-calcified plaque burden, if you're able to get that from a scan, absolutely should drive your decision about pushing LDL lower. You should use higher intensity statins, bring in the PCSK9s, all the big guns if you can do it. And if you're like me, you disregard the guidelines and push LDL as low as possible. That's what I do, that's opinion. But trial 4, iModern, instantaneous wave free ratio mode, or I should say moderated revascularization. I put this in here because if you go out onto the Twitterverse, this is the one that everybody in the actual imaging world, the imaging nerds that didn't sit at the cool table during cardiology fellowship, are all excited about this one. And so the issue is there a role for cardiac MR in guiding revascularization in these non-culprit lesions and STEMIs? And if you take a sort of MRI physiology guided approach to these lesions, does it work? This was published in the New England Journal of Medicine. I think this was kind of a silly setup, but we can talk about why I think that is. So here's the clinical question. In STEMI patients that have multivessel disease, is immediate non-culprit PCI superior to deferred ischemia-guided revascularization? So as a prospective, randomized, open-label non-inferiority trials, there was some blinded adjudication of clinical endpoints. 1,146 STEMI patients, that's a lot of STEMIs, and they all had at least one angiographically significant, so we'll call that greater than 70% stenotic, non-culprit lesion. And they all, of course, survived their STEMI and had their culprit STEMI lesion intervened upon at the time of the index event. So they compared that to IFR-guided PCI in the non-culprit lesions during the index hospitalization, not necessarily the index procedure, versus a deferred approach to getting cardiac MR-guided evaluation with selected delayed PCI, looking at the primary outcomes of all-cause death, recurrent MI, heart failure hospitalization at 12 months. And so this is what they found. There were no significant differences in the primary composite outcome between those strategies. A deferred strategy met pre-specified non-inferiority criteria. Event rates were very low and extremely similar amongst both groups in the trial. There were, however, 33% fewer stents placed in the group that were deferred to cardiac MRI. Non-inferiority, I think, is a point that we have to briefly chat about here because it's frequently mistaken by physicians and in marketing when the reps come to try to sell you on the latest, greatest piece of equipment, as demonstrating that an intervention is as good or better than the standard. And really, the only thing you conclude from a non-inferiority trial is that, the data would support that it is not unacceptably worse. I put that in italics. That's how I like to think about these trials. I don't particularly like non-inferiority trials, but unfortunately, they're pretty much all the rage these days. So non-inferior deferred equals immediate, 33% fewer stents, no increase in death or MI. So the bottom line here is deferred ischemia-guided management of non-culprit lesions is safe and it's evidence-based, and it does avoid stents in 1 out of 3 patients, and that's not a small number. Now here's Damian's take on this. Has anyone ever seen a cardiac MRI done? So I had the opportunity when I was in training to work on the cardiac MRI service at the University of Chicago, and I will tell you, on our busiest day, I think we achieved 4 of these. We were able to do 4 over an 8 to 10 hour clinical day. They take forever. You get a ton of views. There's a ton of setup. There's a ton that goes into these, and they take a long time to process and read. I think it's getting a little better now, probably with AI. They can trace out some of the endocardial borders and things to get quicker and faster measurements, but it was a tedious process back then, and it's maybe a little better now, but not much. And how many of you guys practice in the cath lab besides Dr. Manavati? Anybody else cath lab guys? So if you work in the lab, how would you describe IFR, Dr. Manavati? It's pretty quick.
5 minutes max.
Right. So the way I think of this trial, it's like me doing a clinical trial to tell you that, you can hop in a canoe and you can paddle your way over to Maui to get pineapple that is non-inferior to the ones we could buy here in San Diego. I mean, this is a huge lift, right? And you have to put yourself, I think, in the context of a STEMI patient in the cath lab at 2 a.m. You've got a guy with a 90% LED widowmaker coming in with 1 foot in the grave and another on a banana peel. He's trying to die. You get the lesion open. It's such an easy lift to go in there and look at that other non-culprit and get your answer. That you're going to close up shop and you're going to send this guy down to get a cardiac MRI. Just, to me, the premise is a little crazy, but this one got a lot of talk this year, so I couldn't not present it here. I think it was obligatory, and I apologize if my commentary on it offends anyone. But so obviously, ESC guidelines going back to 2017, complete revascularization recommended, but the timing as to when you fix the non-culprits is flexible. Physiology-guided strategies are reasonable. That would include something like this. Non-culprit PCI is also reasonable, but not mandatory at the index event according to our American guidelines as well. So does this really change anything? I don't know. It's interesting. It was an open label design. It has limited power to detect minute differences in those endpoints. And again, how much does it apply? I really think that depends on your access to CMR. I think this is not a ubiquitous option, I think, at many institutions, even here in San Diego, which I think we're largely ahead of the curve on imaging. But the CERTAIN trial for our grand finale here, coronary evaluation risk assessment via AI assisted quantitative CT. So this looked at clinical decision making using artificial intelligence in CT, and does this change physician confidence in planning? This was from the European Heart Journal. So does AI quantitative CT improve the certainty in downstream clinical management decisions? It was, again, a prospective multi-center crossover trial with sequential interpretation of CT coronaries using standard visual assessment versus an AI-guided approach. Looked at 5,000 patients, thereabouts, and this was actually interesting because we had both cardiologists and radiologists looking at these, not just cardiologists. And again, we talked about this, again, looking at stenosis, plaque volumes, low attenuation plaque, and then this also added a 10-year MACE risk score. And the outcomes wanted to look at a change in physician diagnostic confidence and changes in the way we test downstream, and potentially modifying our treatment recommendations. There is a 2 to 5x increase in diagnostic confidence when we went ahead with the AI-assisted approach. 23% more of these patients were initiated on statins, and 15%, there were 15% fewer people referred for invasive coronary angiograms. So the takeaway here is that, yes, for sure, AI is coming for our jobs. It increased diagnostic confidence. 89% of physicians had significantly increased confidence after they used the AI-assisted tool. There was a reduction in downstream stuff like CAS, which can be quite labor and resource intensive for hospitals and hospital systems and even individual doctors. And so it also did seem to get the prevention train moving a little bit quicker. 18% of these folks got aspirin that probably otherwise wouldn't have. So it does seem to have a meaningful impact. And it's, again, going back to what we talked about, it really does seem to kind of move us more towards looking at plaque biology. So this is the summary slide of everything we just talked about. 5 things to take away from my talk today. Number 1, non-obstructive coronary disease is bad. It is not benign. 70% of events occur in patients that don't have what we would historically define as an obstructive lesion. And this sort of new cool thing that we have called fat attenuation index looks at inflammation, which appears to be driving risk. Women are very different than men in terms of their plaque biology and the way that we have historically treated them. They have more non-calcified plaque despite having lower calcium scores. And that's something, again, that I think that would be a question for the follow-up here in our little fireside, because I think coronary calcium scoring is one of the most confusing things for non-cardiologists and maybe even for cardiologists. Total plaque volume beats percent stenosis. Non-calcified plaque volume predicts adverse events better than just looking at how tight a lesion is. And I put a little asterisk here for those of you that know these trials. The ASTRA trial looked at rosuvastatin quite a few years ago. This was one of the first trials that really showed that plaque regression is actually possible with medical therapy, at least soft plaque. So you put people on, I think they were on 40 of Crestor and Asteroid. Mm-hmm. We did see gradual sort of washing away of some of these more dangerous soft plaques. Saturn, I think, was Atorva, and then Pac-Man was Praluent, which was really great because this is one of the first PCSK9s that we could really push LDL super low. And one guy in Praluent came back with an LDL of 1, and his ApoB basically confirmed it. So CMR can guide multi-vessel revascularization. I mean, I don't know, this is kind of, it is what it is there. It's interesting. If you have a cardiac MRI scanner, maybe think about it. And the quantitative CT, this is really kind of a preview of what's to come for us, which is that we're going to be using these AI tools more and more. They're going to become integrated into our practice. So again, there's the map. We were stenotically focused. We looked at plaque. Now we're on to biology. It's basically everything I just said. So what can you do in your own practice that you take away from here today when you leave? You can order these quantitative CTs now from certain vendors in the area. I won't endorse anyone in particular, but they're there. You can look around. Don't dismiss normal coronary CTs because non-obstructive coronary disease is not low risk. Think about looking for inflammation and non-calcified plaque. Definitely don't let a woman talk you out of putting her on therapy if she has a calcium score of 0 and other things are going on. And then I did put the names of the platforms. These are not local vendors, but this is the technology. Clearly is the one that you'll see most commonly here. You ever have somebody that wants to fight with you about starting lipid lowering therapy, and they're convinced they're fine because they eat salmon or a Mediterranean diet, order a Clearly scan and have a box of Kleenex ready when they come back, because this will scare the bejesus out of them. It's a very sensitive test. So today we're discussing, options about quantitative CT. Start looking around, shop around, find people that do this, think about using it. Longer term, think about how we're going to treat people that don't have that end stage of coronary disease, the calcium, that do have these sort of soft plaques of varying biology. And then medium term, how do we really integrate plaque data and the biology of these plaques into how we approach risk discussions with patients, especially when we're talking about initiating therapies. So that's it. Here we are. See more, treat smarter, leverage AI. We've got the tools, so we can start this journey, I think, today. For a long time, I think CT coronary imaging has not been great. It has burned me many times. It has told me people have horrible disease when they don't. And it's done the opposite as well. But I think we're getting there. I think the AI is helping us. And so that's kind of the theme of what's going on in terms of stuff that I think is really going to move the chains a little bit for us in 2026 in our clinical practice, at least from a primary prevention and secondary prevention standpoint with ASCVD. So this is going to be your cardiology fellow in a couple years. This is the Optimist bot. He's doing a great job. He's got the guide catheter kinked there at a 90-degree angle, so that's going to go real well. That's it.